turn it over to Ben and our fabulous keynote. Thank you.
Amanda's being shy because she's really responsible for a lot of this great work. I'm going to do just a brief introduction and just sort of present kind of why we thought about this topic, but we wanted to talk about well-being, and I think all of you in this room or online, I think, are aware of what a crisis we're having in the healthcare worker space, whether it be nurses or physicians or advanced practice providers. I think, unfortunately, those of us that are caring for these vulnerable patients, maybe also vulnerable patients, and it's pretty acute, and unfortunately I've had a chance to see it up front with some suicide attempts that we've had to care for in some folks on our team recently. So it really rose to the top and made us think, like, what resources should we be bringing to our community, not just our patients, but our providers and our nurses. And when I think of our mission and our vision, which is partnering to create and care for the healthiest community in the nation, I really think community includes our workers. And I think if our workers aren't doing well, aren't thriving, it's really hard for our patients and the rest of the non-healthcare community to thrive. So that's what kind of motivated us. So I'm really excited. Just had a few minutes to talk to our keynote speaker, Dr. Maire, I think I said that right, Daughtery, who's got a really interesting background. I haven't really encountered this, but a physician anesthesiologist working for 20 years locally, but also has a really keen interest in mental health, and went back and got her master's degree in psychology, and does both. So she's doing anesthesia as her, day job, and then on the side she's working with physicians, healthcare workers, and others who are experiencing mental health, substance abuse, and other issues. And so she's going to talk a little bit about well-being, and thank you for coming to speak with us.
Okay, so the first thing is technology bringing up my talk. I think I found it right here. Part of presentations always is working out the bugs. Yeah. Always. Okay, and I just click.
And so we'll do full screen, and then
I just click that. Okay.
Yeah, you should be good to go.
Thank you very much.
Yeah, of course.
So first of all, thank you so much for inviting me to speak. You have no idea how much I appreciate this. And I also want to just comment, I've been so impressed with the presentations recognizing the problems that we face in the behavioral health world. And thirdly, that I very, very much love the behavioral health world. I was exposed to it in 2015 when I decided to go back to graduate school and do a master's in clinical mental health counseling, because my specialty, the specialty of the practice of anesthesiology, has a very high rate of completed physician suicide. So this is a topic that is near and dear to my heart, and my hope is by the end of this talk you will understand very clearly why I call this a sacred process. So I started my practice in Oakland, California. I was a cardiac anesthesiologist at the time, and at the time we would induce our patients with an enormous amount of fentanyl, that short-acting narcotic that is so well known now. And one day we found one of our anesthesia techs, absolutely beloved person, down in the bathroom with my 20 cc's of fentanyl hanging out of his arm. And I knew it was mine because I counted at the end of my day, and I couldn't account for 1 ampule of fentanyl. And I thought, well, maybe I miscounted, maybe I gave it and didn't realize it. You know, you go through all of those things. And then, of course, when we got that news, I knew exactly what had happened to that ampule of fentanyl. I've also had 4 partners over the course of my career complete suicide, 2 of whom were very good friends. So this is a very important topic. Spacebar. Spacebar. Let's see. I might need a little IT help here to move my slides forward. Maybe it's the arrow. Should I try it? Oh, there we go. Okay. Got it. So I have 3 hopes for this presentation. My first hope is that you don't fall asleep, because that's my other profession. My second hope is that at least a few of you take away at least a few pieces of information that are useful. My third hope is that at least a few of you walk away from this tragic problem with a little bit more of a sense of empowerment. The way I chose to approach this is really from a perspective of looking from the outside in. And the reason for that is because when I went back and did my degree in mental health counseling, it was the first time I'd really stepped outside of the physician's environment. It was the first time I became aware of some of the things that we take for granted that really are not healthy and that don't necessarily have to be that way. So I'm going to talk about some of those perspectives from my point of view, for how it applies to you, the physician, and really how it also applies to our patient population, many of whom are so frustrated with us as physicians for reasons we're going to talk about. I'm going to start by defining well-being so that we're all on the same page in terms of what we're talking about. I'm going to talk about our strengths. I'm going to talk about our growth edge, or our areas for growth, which is a term I much prefer compared to our weaknesses. And I'm going to talk about some strategies which are very, very simple, but not easy to pull off. So what is well-being? So in sort of skirting through the literature, I landed on the American Psychological Association's definition, which they revised in 2018. And to be perfectly honest, it's so general as to be almost useless, but there's one piece here that's really important. So I am going to read it to you. They define it as a noun, a state of happiness and contentment with low levels of distress, overall good physical and mental health and outlook, or good quality of life. Well, I will tell you that all of this is subjective. All of this is subjective. I just spent a week in the Philippines with people living in abject poverty, whom I would qualify as living with a sense of well-being. The important part of this definition, in my estimation, is that comment about low levels of distress. So how do we navigate our stressful lives, because we all suffer from stress in our lives, with a low level of distress? And I would qualify that as really as an experience of our self, which we don't talk a lot about in medicine. So we're going to talk about that today. So let's start off with our physician population. We are a really privileged population of people. We are extraordinarily well educated. We are financially well off. We may not be wealthy like the general public thinks that we are, but none of us wonders where our next meal is coming from. We command an extraordinary amount of respect despite the shenanigans of the pandemic, right? We still command an extraordinary amount of respect, and we are privileged. We are privileged. So what's the problem? The problem is our rates of burnout in our population are extraordinary, and that preceded the pandemic. You can only imagine what happened as the pandemic unfolded and where we are now. We have extraordinary high rates of depression, anxiety, untreated PTSD, substance use disorders, and finally, and most tragically, we have a rate of completed suicide that well exceeds the public population. So what the heck is going on here? So let's just stand back for a minute and put a timeline on some of what I'm going to be talking about. Before the pandemic, we were starting to talk about, in the general literature, rates of burnout, which seemed to be very high, rates of suicide, which seemed to be very high. We were just beginning to talk about that. It had just become less of a taboo subject. Papers routinely identified burnout rates of over 50% in the physician population. And then there were studies done to identify what's leading to this problem, and the American Society of Anesthesiologists published a paper in 2021 which identified some of those problems: lack of support, inadequate staffing. Other studies talked about our EHRs, which demand increasing amounts of time, and our administrative duties, which also separate us from our patients. And all of these come together to provide an environment that is very challenging to work in today. And then the final insult is reviews from patients, 1 star to 5 star. How do we earn 5-star reviews in the context that we're working in? And those reviews determine how we're perceived and how we're paid. And we cannot respond to those reviews, one for HIPAA reasons and two for the entities that we work with. So there's no interaction there. It's a power imbalance system, and we feel powerless about that. I hear a lot of physicians talking about that in my day-to-day work world, in the people that I spend time with, all across social media. That topic comes up over and over and over again, that sense of powerlessness. So what was proposed to fix this problem of inadequate staffing and too much administrative work? Well, here's a mindfulness app. You should do some yoga. Here's 5 therapy sessions. Now, in and of themselves, those are really important tools. Not to denigrate those tools, but those don't address the problems that we're actually struggling with. So those are non-answers to this problem. So all of that was before the pandemic, and then the pandemic unfolded with all of its issues, and there was a mass exodus of physicians. And I will tell you in my practice, just generally speaking, things I hear over and over again, a deep sense of betrayal. I spent my whole life training for this. I care about my patients, and now my patients are flinging things in my face that make no sense to me. You're trying to hurt me by pushing this vaccine on me, et cetera, et cetera, et cetera. So we had a mass exodus of physicians during that time, an acceleration of retirement. And so now we come to our current state of affairs, where we still have inadequate physicians trained to do the work that needs to be done in the United States of America. We have struggled with a dearth for a long, long time. Just now, our government is funding increasing residency slots, so we do have more physicians being trained, but it is not nearly enough. It doesn't come close to enough. And we have an aging physician population, 59 years old. I will not be working into my mid-70s like my father did. I watched him and said, that's not for me. So we have an aging population that will continue to contribute to this staffing shortage that we're struggling with in the United States in our medical care. So looking to the future, there are lots of discussions happening now, which is reason for hope. There is attention being paid to wellness programs, and all of this is good news. And so we're going to focus a little bit on that, and then finally we're going to focus on what I perceive of as the fundamental need in medicine, which is really an overall cultural shift in how we perceive ourselves and in how we perceive our work and the rights that we have in our work. So let's go back to our concept of wellness, a very important concept. And in fact, why can't we just apply positive psychology to this problem? Well, let's talk about that. So first of all, what is positive psychology? It's a theory that was started by Seligman, and he identified 5 variables that seem to be important in people's sense of well-being. The experience of positive emotions, engagement in something that really draws you in, that allows you to get into the so-called zone or into a flow. Relationship, meaning, and accomplishment. So I think we can all argue that we can set accomplishment aside for this particular population. We're well endowed in the accomplishment arena. So we're going to talk about some of the other areas in positive psychology that may be applicable to us. However, there is a problem. Positive psychology asks us to lean into a gratitude practice to experience the positive emotions like joy. It requires us to cultivate our self-confidence. But there's a problem with that, and the problem is that happiness psychology addresses how we flourish, and it doesn't talk about alleviating suffering. And alleviating suffering is one of the problems we really need to address. So I'm going to talk about 3 problems that come to the table in our work environments to provide a really negative synergy that is contributing probably to the astronomical problems that we are starting to see in our physician population. So there are what I regard as corporate and administrative barriers. We are a for-profit system in the United States of America, and we are patient-centered practitioners as physicians. And as you can imagine, sometimes we butt heads over that. So for me, in my world, it's I have to bring my patient on time to the operating room. Otherwise, there's punishment for that, right? Because we got to keep the system moving. So how do I navigate connecting with my patient making sure they understand that I hear them, I understand their concerns, and I'm taking their concerns into my consideration, into my anesthetic plan, bringing them to the operating room, getting them safely through that procedure, bringing them to the recovery area, dropping them off with our very trusted nurses, and then moving on to take care of the next patient. Some days not so bad, some days a lot of pressure, a lot of pressure. And that doesn't even come close to the pressure that our primary care doctors are struggling with, where they're being asked to see more and more patients with less and less time. And that is really problematic because it doesn't give us time to exercise empathy, which is a fundamental piece of the relationship in a caregiver, care-needing relationship. So what we end up with is a population of patients who don't trust us anymore, who say, my doctor doesn't listen to me. My doctor didn't spend time with me. My doctor didn't even bother to read my chart. Well, the reality is your doctor did read your chart. Your doctor was probably up till midnight finishing charting and preparing for the next day. And even though they only spent 7 minutes with you, that 7 minutes was packed with a dense amount of underlying information to help you be treated the way that you're supposed to be treated. But the fact is, if our patients don't trust us, they don't undertake our recommendations. So that's our environment, our corporate administrative goals versus patient care goals versus physician-generated goals. But then there's really what we bring to the table, and this is something that really came to mind as I spent the last 10 years immersing myself in behavioral health and mental health. There are some things that physicians seem to have in common, and one of them is a deep level of insecurity. We all talk about that sense of imposter syndrome, and I know this isn't only exclusively found in the physician population, but I can't tell you how many times I find myself saying, so help me understand, you feel like a fraud after 12 years of intensive education and training, giving up everything, family, friends. We don't even remember what was happening politically during the time that we trained because you spent so much time training and you're telling me you feel like a fraud? Help me understand that. We struggle with perfectionism. We can't turn out a work product until it's perfect, and that contributes to our long hours because we can't just get the work done, turn it off, and go home. We have to make sure we didn't miss a critical lab value. We have to make sure we didn't miss a vital sign that contributes to the patient's overall picture. There's so much going on when we're thinking about our patients. We also struggle with a harsh internal critic, lots of us. And I'm going to talk about an anecdote, and in order to protect identity, I'm going to call him a he and I'm going to call him a cardiologist, but this could be anybody. Sitting in the lunchroom at work, shoveling food in between cases, and I hear cardiologist talking on the phone, clearly to a trainee on the other end of that phone, just listening to the conversation. And he was terrible. He was awful. He berated that resident. Well, why did you call me after not having gotten all the information how did you even get into medical school? Right? He was humiliating. And this is not particularly unusual in our training environments. And what I understand from my perspective as a therapist, now looking back, is that that same voice that he was addressing his trainee with is the voice that he addresses himself with. Because we internalize the voices that we grow up with, and that's the voice that we live with. And we don't distinguish between me and you with that voice, right? I demand from myself what I demand from you. And the problem is when you get a lot of that in a training environment, all of a sudden the training environment has the potential to become toxic. We lean into external validation, very much so. I do the things I do because I want you to tell me I'm doing a good job. I need to hear that I'm doing a good job. And sometimes we drive ourselves into the ground doing our work just for that external validation. So part of the work that I do is I talk about the difference between external validation and your internal sense of self that leads to a sense of well-being, that allows you to manage stress with lower levels of distress, as our APA definition discussed. We also struggle with a lack of emotional boundaries. I won't elaborate on that now because I'm going to elaborate on it in some slides moving forward. We also struggle with the compartmentalizing of feelings, and I will tell you, in my psychotherapy training, this really came roaring to the surface. So in medicine, we learn your job is to take care of the patient, and in order to do that, you push yourself aside. You push your needs aside. You're feeling sad, tuck that stuff away. We don't deal with that here, okay? In therapy, you learn that the most important tool is the self. So we attend to taking care of the self. You can imagine that being asked as a therapist to sit in a chair hour after hour, immersing ourselves in the suffering of others. We really have to come to this present and grounded. And we don't do that by compartmentalizing our feelings. We, in fact, do that by feeling our feelings, by being intimately connected to our feelings. And then, just to reiterate, that total neglect of self, that is part of our medical education and training. So that's the corporate piece. That's the piece that we bring to the table that synergizes so negatively. And now I'm going to talk about some of the problems that come up in our environments. And I'm going to spend a few minutes on each of these topics. They are all big topics. I could talk for an hour about each of them. I'm going to talk about moral injury. I'm going to talk about vicarious trauma. I'm going to talk about compassion fatigue. And I'm going to talk about second victim phenomena from the perspective of the physician. So moral injury was defined in the 1980s in the population of veterans returning from war, where they described going to war with a particular goal. So for example, I saw 9/11 and I wanted to make sure nothing like that ever happened again. So I went to war, and what ended up happening was I saw and did things that were horrifying that I can't live with. There was an art installation that was put together, and I'm going to describe it because I think it describes really powerfully the essence of moral injury. So it's an art installation, right? It's a dim room, chairs in a circle, people come in and sit down in the chairs, the lights go down a little bit more, and all of a sudden these disembodied voices start talking and describing their experiences in the trenches of war. Somebody threw a hand grenade into my group. Most of my buddies died. I turned around to see who threw that hand grenade. It was a 5-year-old, and I shot and killed him. And I can't live with myself. It goes in my head over and over again. So this is intense moral injury. From a medical environment perspective, I like to think of moral injury in the physician world as death by 1,000 paper cuts. So it is, for example, in the middle of a pandemic, wheeling a patient down the hallway to the operating room, and a nurse manager calling and saying, by the way, you can't use the powered air purifier or PAPR system because we're saving these for an emergency. That's a hard stop, folks. We were in the middle of a pandemic and had no idea how this virus worked. And this was going in and intubating, being intimate with somebody's airway who was potentially or sick. This is moral injury. Moral injury is walking into an operating room that is theoretically set up for some of our most catastrophic cases, where we have to be on top of it, patient asleep, things taken care of within minutes, and recognizing instantly that there's no massive blood transfusion entity in the corner. We're missing some of our critical emergency drugs. And in fact, I don't know if any of you or many of you are familiar with what we call a glide scope that's pictured on the screen here. We use this for difficult airways, for intubations that are challenging. And you can imagine in the middle of an emergency, we want everything at our fingertips. The adrenaline is flowing and time is of the essence. Well, this glide scope doesn't have the handles or the tubes or the stylets required to make this piece of equipment useful. So walking into an emergency setup and seeing there's some critical pieces missing, that's moral injury. What else is missing? When am I going to walk into an operating room and find the thing I need is not available? This is not acceptable. Moral injury is financial decision-making versus patient-centered care. Moral injury is having to call the insurance company to argue for the treatment that I've requested for my patient. Prior authorizations. It goes on and on and on. This is much of the challenge of the work that we do. So when we walk in and spend 7 minutes with a patient, they don't understand all the work going on in the background that leads to that 7-minute interaction that's happening. And how do we communicate that to our patients? So one of the really challenging things in terms of the time within which we have been required to work more recently, and I will tell you, it was not like this in 2000, 2005. This has changed over time, is that we don't have time to develop the relationship with our patients that allows us to do the work that we do. Empathy is one of the central pieces of the work that we do. Whether you're a psychotherapist or a physician, empathy matters. Danielle Orfrey, in her book, What Doctors Feel, if it's been a long time since you've been a resident or an intern, I recommend going back and looking at it, because she talks about all of the things that we go through as trainees. And when I reread it in preparation for this talk, it brought chills to my spine. It was like, oh yeah, that's what happened. That's what happened. One of the things that she described was doctors during that time going into an indigent population of patients and really developing rapport with them so that they could understand what was happening for the patient and treat the patient effectively. So now we're going to move into vicarious trauma. And I don't know how many physicians are watching this or are present, but I would like to ask you to go back to a time when you were a trainee and go back to the experience of your first patient death. That may be a long, long time ago for some of you. It was certainly a long time ago for me. I trained in the 1990s. But I vividly remember my first patient death. It was a patient in the intensive care unit. Her husband did not want us to let her die, and we coded her literally all night long. And in between resuscitations, we would go out and talk to the husband. She is dying. She is going to die. Please let us let her die. And at the end of the day, we did let her die. And the picture that I have emblazoned in my mind is the husband sitting next to his dead wife sobbing. It was awful. It was awful. I don't remember debriefing with our ICU attendings. I don't remember anything related to the fallout after that. I do remember going home and bawling. So our program actually was really advanced in terms of how it tried to help its interns manage all of these feelings that we were dealing with as new physicians, the anxiety, my nurse wants Tylenol, and I'm not even sure I can prescribe Tylenol without worrying about the repercussions of it. Is such an anxiety-provoking time. It is incredibly stressful. Well, so they provided group for us where they would get us together periodically to sit in a circle and talk about what was happening for us. The problem is the person facilitating group didn't actually know what she was doing. So what would happen is, for example, I remember one of my student colleagues speaking up and saying, I feel so overwhelmed. I feel overwhelmed and incompetent as a doctor. I feel overwhelmed and incompetent as a wife. I feel overwhelmed and incompetent as a mother. I feel like I can't do anything right. And the facilitator said, okay, next. Boy, that is really how somebody who doesn't know what they're doing causes harm, because what was the message that we all took away from that? The message we took away from that was, don't talk about your feelings. What should have happened in that scenario? What should have happened was the facilitator should have leaned in and said, wow, I recognize that you were so brave in sharing this. I hear that you're feeling really overwhelmed. I'm going to guess that you're not the only one in the room feeling overwhelmed. And then sit back and wait for the conversation to start. Wait for people to begin connecting and recognizing that they're not alone, and begin to develop community that helps you navigate this difficult situation that we're all in together. So it was an attempt. So vicarious trauma in our worlds, as we move through the practice of medicine over the course of years, beyond first experiences, as patients die, we discuss end-of-life issues with patients. We deliver bad news on a regular basis. I'm sorry, Mom, your child has a lethal diagnosis. I'm sorry, sir, you have a diagnosis that's going to impact the rest of your life in a really negative way. We deal with gunshot wounds. We deal with car crashes. We deal with all sorts of tragedy, and we forget the feelings associated with those tragedies because we're engaged with them on such a regular basis, and we don't have enough time. So I was in the emergency department not too long ago, 52-year-old white male motorcycle crash, no helmet, moderate speed, clearly severely injured, comes in, ER doc, trauma surgeon there, managing the whole thing. As an anesthesiologist at my hospital, my job is to stand back and watch and be there in case there's a need for my help. So the airway is difficult and I need to step in to help out with that. Or facilitating bringing the patient to the operating room should there be a need for that. That's my role. It's a little bit luxurious for me, right? Because I get to stand back and watch. And I'm watching my ER doc and I'm watching my trauma surgeon and I'm marveling at their focus and the work that they're doing. And I'm also looking at the patient, and it occurs to me, 52-year-old white male motorcycle enthusiast. I have a scrub nurse who's a Harley enthusiast, and her husband and she go out riding regularly. That could be him on the table. And then I started to really feel for this person on the table versus just a motorcycle crash coming in and needing to be taken care of, right? I could feel myself tearing up a little bit, which is relatively new for me in the span of my career. And I'm aware of what's happening, and I'm letting it happen because I know it's important. And I'm also not in a position of being highly focused doing the work, so I have that luxury. And as our ER doc is getting ready to intubate him because he needed his airway controlled, the patient's arm goes up and he says, "Please, somebody help me." And I can't tell you how I felt that. And that's what brings meaning to my work in our very challenging circumstances. I don't forget that it's a patient that we're dealing with, but that is an active process. We remind ourselves that. And frankly, if we don't, we risk compassion fatigue. And what is compassion fatigue? It is a real separation between us and our patients, between us and the meaning in the work that we do. It is a sense of derealization. It's a numbness. It's an I don't care. It's a cynicism. It's a horrible way to feel. It's a precursor for full-on burnout, which I'm going to talk a little bit more about. So what is burnout? Burnout is an occupational hazard specifically identified by the World Health Organization where people feel a sense of lack of efficacy. I don't feel like I can do my job properly. I don't want to show up to my job. In fact, the job that I loved, I find that I hate. I think about it overnight. I don't want to go to work the next day. It's a feeling of depletion. It's a horrible feeling. Now I'm going to lean into second victim from the perspective of a physician because this is one of the most dangerous positions a physician can find themselves in. This is where a mistake is made and it leads to either serious injury or death of a patient. Nothing feels worse. Nothing. I 100% guarantee you. It is showing up to the hospital burning with shame, feeling like all eyes are on you. Oh, you're that doctor that killed that patient. That isn't necessarily what people are thinking, but that's what you're thinking as the physician involved in that particular event. It is shame, it is guilt, it is profound second guessing of your skills and your talent and your depth of knowledge. It is becoming more and more meek as a practitioner. In the hands of an anesthesiologist, it would look like, we're going to cancel that case because I don't think that patient's ready. They need to be optimized further. It looks like everybody gets an A-line because I really need to pay attention to that blood pressure because I don't want this to happen again. It looks like withdrawing from care over time, and sometimes it looks like leaving the field entirely in many different ways. But it doesn't have to be that way. And in fact, studies have shown that there are things that we can do as physicians in this position to help ourselves and help our community and continue to practice the art and craft of medicine that we worked so hard to be able to do. And that is to identify systemic problems associated with what happened and become very involved in fixing that systemic problem, really hoping to assure that this doesn't happen again, either to the patient or to my partners who are also at risk of making a mistake. And quite frankly, we are all at risk of making a mistake because we are human. We're all at risk of making a mistake. We walk into our workday every day with the possibility of hurting somebody, and that's a profound burden to carry that we typically carry in isolation in a siloed state. We don't talk about this amongst ourselves. It is engaging meaningful change. It's finding other people who've had these experiences and connecting with them. Much like our group experience that should have unfolded, it's the ability to find others to commiserate with, right? Others who understand, yeah, I've been there. It gets better. It's hard. And sometimes it's finding a caring professional to talk with, i.e. a therapist, to help move through this really difficult space that we sometimes find ourselves in as physicians and that we are always at risk of on a day-to-day basis when we go to work. So that's a lot of crepe that I've hung. I'm going to turn around here and talk about our strengths, because I want us to remember we do come to this with enormous strengths. We have a depth of knowledge that is unparalleled. We are driven. We care. We are empathic. We have an ethical code and a sense of values. We are curious. We are caring. We have extraordinary stamina. We are resilient. We have all of these things that we bring to the field. So let's capitalize on this. Let's talk about how we alleviate suffering so we can move into flourishing, at least somewhat, in our environments. So how do we alleviate suffering? Well, the first thing that comes to my mind is community. We need to really focus on actively building community within our practices so that when my partner completes suicide, it's not a surprise to me. I don't wake up one day and learn that this happened and I'm stunned by it, right? Because I've connected with my partner, and if my partner's in trouble, we talk about it, we do something about it. So community, that looks like, in my thinking, informal and sometimes formal peer support. In my world, and I don't know what this might look like in a primary caregiver's world, but I can speculate. In my world, it looks like if something catastrophic happens in the operating room, I am deliberately reaching out to my partner to make sure they're okay. And I'm inviting them to talk about how they feel. I don't just sit and accept, oh yeah, I'm fine. Yeah, we knew it was gonna happen. Because I know there's more to it than that. So I go after them a little bit, and we talk about it. And we've developed more of a culture in my working environment where when something catastrophic happens, we talk about it, and we talk about how we feel about it. That was awful. I'm gonna go home and cry. I really wasn't expecting this person to throw a PE on the table and die right in front of me in the middle of his otherwise elective simple procedure, right? We see these things, it's terrible. Formal peer support is a process put in place which allows this to happen on a more global spectrum. So I work with my anesthesia partners, I work with the surgeons that I work with, but I don't go up and talk to the internists on the floor because I have very little connection with them. Formal peer support actually puts this in place for everybody, and it allows the building of community. It allows us to acknowledge that, in fact, we are vulnerable. In fact, we are humans. As much as our training programs would like to tell us that we can subvert ourselves to take care of patients, the reality is that's not how it works. It mitigates some of the risk for PTSD just by talking about the experiences that we've had rather than avoiding them. It supports the idea of asking for help rather than pretending that we are invincible. And it also allows us to share resources. So if I have a partner who's looking a little down, or I'm worried about them for one reason or another, I say, hey, think it might be helpful to talk to a therapist? I have some names. Come talk to me. So part of the problem with that is physicians don't really know what therapy is about. They often come in, they sit down, they're like, okay, here's my problem, tell me what to do. Okay, that's not what therapy is about. Therapists know that. So I spend a lot of time educating people in terms of what is happening in that therapeutic system. So the first thing that's important is the most important factor related to change is the therapeutic relationship or the therapeutic alliance. And that means the relationship between client or patient and clinician. It means that you come in and over time you learn to trust me with your deeper and darker secrets. It means you become more comfortable talking about things that are really uncomfortable. That is the work of therapy, and it is really hard work. It is also an experience, sometimes for the first time in years, of being seen and heard and understood. And I can't tell you how powerful that single intervention is. It is somebody witnessing your pain and recognizing that it's important and that your feelings matter. It is also a technical approach to understanding how our brains work. Our brains are pattern-seeking little organs, and so we as therapists are working very hard to hear the patterns that are getting in your own way. So this is part of therapy. What are the tools in a psychotherapy relationship? And I will tell you, for me, that was a really steep learning curve, because in anesthesia, I have my machine, I can ventilate my patient, I can watch the monitors and see their vital signs. Oh, blood pressure's a little low, differential diagnosis going on, checking out some medicines to treat that, talking to the surgeon. There's lots of things for me to do. There's lots of things for me to watch and keep track of. Whereas in therapy, I'm sitting in a chair. What am I doing? It took me a long time to recognize what I was doing, the importance of holding space, the importance of being present, the importance of interpreting what's happening for somebody, the importance of reflecting feelings back, the importance of wrapping language around our experiences. And let's talk about wrapping language around our experiences, because from a depth perspective or a psychodynamic perspective, which is the theoretical framework I work in, Freud identified that as the unconscious. We understand that in current language as implicit memory or pre-verbal memory. In a cognitive behavioral therapist perspective, we refer to that as schemas or blueprints for relationship. And how we develop our blueprints for relationship is really important. It happens in the first few years of life. So when parents say, oh, it doesn't matter, she's 2, she won't remember this, nothing could be further from the truth. In fact, your 2-year-old is going to remember what happened, and they're going to integrate it into their developing brain, and it is going to be part of how they relate to the world. But they're not going to have control over it because they're unaware of it. It's unconscious, it's implicit. So a lot of the work we do in therapy is really trying to recognize those implicit beliefs and assumptions, and then holding them up to be seen and recognized, and then talking about how does this serve you versus how does this get in your way. This is a really powerful process, really powerful. So we also talk about the impacts of what we recognize as a child's egocentric perspective. From a child's developing brain, everything that happens has something to do with them. My parents got divorced because I was a bad child. My dad's hitting mommy because I was bad today. That is a child's perspective. As adults, we recognize generally that, daddy was drinking too much. He had an alcohol problem. That was really the problem. Mommy and daddy got divorced because they weren't a good fit. The problem is we can recognize that cognitively, but we don't recognize that emotionally. And so one of the things that happens in therapy is we help people recognize emotionally what was really happening. And so you can see it in somebody's face. Oh, when I was 5 and my mom was yelling at my sister, and I thought, what did I do to make this happen, and why couldn't I stop it? All of a sudden, I had no control over this. You can see that emotional insight happening, and this is what leads to change over time. So, what is it that's happening in that early developmental state? We're going to talk a little bit about the psychological birth of the child, because this is really fundamentally what we're working with. Margaret Mahler did observational studies which really identified what was happening in the infant brain as it was developing. So infants are not born understanding, you're you, I'm me, this is happy, this is sad. The infant brain begins to understand that in relationship with the primary caregiver. So in working with mom or dad, whoever the primary caregiver is, in my case it was dad, infants learn that I'm me, you're you, we are separate entities. This feeling I have in my tummy, this is hungry. This feeling I have is frustration. This feeling that I have in my tummy is happiness, right? We learn that in relationship. So you can imagine that a baby born into a family where the primary caregiver is struggling with postpartum depression doesn't necessarily develop that depth of feeling. This has profound impacts on our relationships as adults. And so that is also part of what we're doing as clinicians in a therapeutic relationship. So Anne Gregory Hamilton described in his beautiful book, Self and Other, the reality that who we are depends very much on who we are hanging out with. He identified a study that was done that was really an attempt to identify the variables of brainwashing in World War II, where people were put in a completely sensory-deprived environment, and in that sensory-deprived environment, their self started to disintegrate. They couldn't distinguish between real and not real. They started to hallucinate. And he speculated that that was a reflection of being completely separated from your senses and the people that you are surrounding yourself with. We see this in addiction work when we talk to patients moving from a residential treatment setting out back into the world where they are now vulnerable for relapse. And we talk about the very painful fact that you may have to find a whole different group of people to be with. Because if you go back to your using group, you will most likely ultimately relapse back into being a user. You have to surround yourself with people who share your goals, who share your desire to maintain sobriety, because who you are is who you hang out with, much like what we eat is what our body is. So I'm going to whip through a couple of slides here because they're really important, but I recognize that I'm running out of time, and I also want to leave some time for questions. We talked a little bit about compartmentalization, the idea that our feelings are really important. Our feelings are what make our work meaningful. It's what gets us out of bed to do the hard work that we do. And to compartmentalize our feelings and never bring them out in processing gets us into trouble over time. Mentalization is the ability to recognize when you're making an assumption about what someone else is thinking or what their goals are, and stepping back and instead of running with that assumption, being curious about what might be happening. Where the best example of that I can think of is when there are two spouses and one is really cranky and the other one assumes that he or she must be really mad at me, where the reality is the spouse had a difficult day at work and that's really what's happening for them. Beginning to recognize, oh, I'm assuming my spouse is mad at me, but maybe they're not. Maybe there's something else going on. And that applies to all of our relationships and all of our communication. We make assumptions about the patients coming in to see us. They make assumptions about us. And it's the ability to stand back and say, I wonder what's going on besides what it is that I'm assuming. And that brings me to projection and projective identification, which I'm going to talk about very briefly because I think this really addresses one of the things that we deal with as physicians working with the general public. People come in with perceptions of us that don't necessarily match who we are. So I might be the caring physician with a depth of knowledge sitting in front of you, but the patient comes in with the idea that you don't care about me, you don't care about what's going on for me, you're a horrible person. Now, as a physician, I can take that in, feel assaulted by that, or I can recognize that this is something that the patient is projecting on me, and I recognize it as a projection because it doesn't match who I am. This is not who I am. So that depersonalizes that interaction. It allows us to uphold an emotional boundary. We don't have to take that in. That's their stuff. That's not my stuff. Projective identification takes it one step further where something is projected onto you and then you are being pulled to act in a particular way. In our addiction population, we're being pulled to hurt people because our addiction clients are some of the most provocative people that we work with. When I work in the GI lab and our whole set of patients all day long are basically patients struggling with the repercussions of long-term alcohol use, those are generally very unhappy people. They struggle with a deep sense of self-loathing, and they are pulling us as clinicians to share that self-loathing. We don't have to. We can either recognize that if we saw where that person comes from, where they came from, how they came to be where they are today, we would actually feel quite sad. We would feel empathy for that. And in fact, their self-loathing that they're pulling from us is the self-loathing that they feel. So this gives us a tool for really understanding the feelings that they are struggling with. We don't take those feelings on for ourselves. I don't loathe you. I don't know you. You're a person I'm taking care of. So it allows us to be more mindful in our interactions with patients. And then finally, countertransference really is that stirring of our own stuff from our pre-verbal experiences that comes to be in the contemporary relationship, but really isn't appropriate to the contemporary circumstances, where in a therapy relationship, we need to be very aware of that so we don't then turn around and hurt our patients. It looks like a client coming in and saying, "You're the worst therapist I've ever worked with. I don't believe you even get paid for this." It means not getting sucked into that and recognizing that maybe this reminds me of some of my own childhood experiences. I feel my heart racing, I feel my palms getting a little sweaty. And it means being aware of that and putting it aside so that I can actually work with what's in front of me, empathizing with the feelings that this person is sharing with me indirectly. The final thing I'm going to talk about is transmuting internalization, and I'm going to come back to that harsh critical voice that our cardiologist shared with us. And I'm going to talk about the therapy relationship over time, taking that harsh critical voice and transforming it into a more compassionate, kind voice. That's long-term work. That's long-term work. How can I best serve? We teach others how to treat us. With all of these things being said, perhaps we have an opportunity to return to our happiness model, to focus on the meaning in our work, which is related to how we feel, treating our feelings like the Krebs cycle. Memorize all the details, really understand, really become intimate with, so that we can be informed by rather than driven by our feelings. And finally, the ripple effect. I just got back from the Philippines with my partner's nonprofit. She started in about 2010. She's been doing 3 trips a year with Mending Faces. I can only imagine the impact she's had on every child that we took care of, that her group has taken care of over time. Mending their faces, their cleft lips, and their complex palates, and providing scholarships for these children to go to school. She impacts the clinicians who go down to take care of these children, and I will tell you what a profound impact that had on me this last week. It was an incredible experience. It impacts the child directly, it impacts their families, it impacts their communities. We as physicians have a ripple effect too. We impact our patients, we impact their families, we impact our community. And that's all I've got for you today. Thank you so very much for listening. I would love to take questions if there are any.
Let's start us off with a question and then maybe take some questions. So, thinking of the ripple effect, when those of us here or listening, sometimes we're aware of people who are struggling, and I think I mentioned to you, they're not always open. Like when you reach out to them, everything's fine. We're doctors or nurses where we're used to putting on that face. Do you have any advice on how we might, deal with that difficult issue?
That's really tricky because we all come at this with a public face, right? I could be devastated inside, but I put on this face that I'm just fine. And we learn how to do that in medical school. We are so good at that. And so how do you kind of pierce the surface of that? Kind of depends. If you have a good relationship with somebody, you can be a little bit assertive about, I know you say you're fine, but I kind of wonder because I see this or because I hear that. And really kind of going after people a little bit more than we're necessarily comfortable with. Maybe you're not comfortable me asking you how you feel, but I'm worried about you. I want to make sure you're okay. I know you have feelings. We all do. Here's some experiences I've had. So if you share your own experiences, you open the door for more intimate conversation. That's one thing I would suggest.
Thank you. Does anyone in the room have questions, comments?
Hello.
Hello.
Enjoyed your presentation. It seems like, from my observation, that there's a lot of systemic, and I don't mean just like one organization, but there's a lot of systemic issues that contribute to burnout. And I was wondering if you had any thoughts about. Yeah.
I do have some thoughts about that. One of the slides I really breezed through. So we teach others how to treat us. Many of us grow up in households that are strict, where we're required to perform, and we learn how to do that. We put our nose to the grindstone, and we do a really good job. And that facilitates training because we put our nose to the grindstone and we do a really good job. I've been up for the last 36 hours taking care of patients in the intensive care unit, but you want me to do another 6? Absolutely, yeah. Sleeping is losing opportunities to learn. That's the environment that we train in. Unfortunately, that doesn't work sustainably in the long term. When we graduate from our training programs, we all of a sudden have to shift our perspective and our attitude. And our attitude needs to become no. No is a full sentence. I know we need coverage for this call, but I'm already carrying a full call burden, and I can't do this. If you say yes, which is our instinct, you are going to be the person that gets come to. If you say no and uphold some professional boundaries, people learn over time, you're not the person that's going to solve this stopgap problem. It's we had a physician retire and we're short, so we need you to pick up that other person's work. No, that's not in my contract. I'm happy to discuss what changes might need to happen in order for me to fill this in, but there's plenty of locums out there to pick up this work. Is that easy to do? No. You know, we feel responsible. We feel like we're shirking our duties if we say no, but the reality is until we're comfortable saying no, nothing is going to change. We will be consistently driven into the ground as clinicians as long as we let it happen. We have some agency over this. I recognize it's really challenging. It is not easy to look at a room full of patients and say, we need to get some more people in here because I can't carry this. I am one single person. And so that's what I mean by cultural shift. It is a focus on what do I need for me in order for me to be sustainable taking care of you, and really valuing that. That becomes a priority. It's not just grinding through. It's stopping and saying, you know what? We need to make some changes here. I wish it were simpler.
Do we have any more questions?
So there are efforts to address this. There was a cap on hours that was imposed on residency training programs. The problem is that doesn't really work because you have this population of clinicians, residents, which get paid almost nothing to work 24/7, 365. And so in order to change that, it's not a matter of just saying, okay, once you finish a 24-hour shift, you have to go home and go to sleep, because that doesn't take care of the need for the work that needs to be done. And residency programs are more or less, probably less compliant with that. They get around those rules and regulations fairly easily. So it's a problem. It is being addressed. It is at least being talked about. And at this point, I would say there really aren't any good solutions proposed.
I think we have time for one more question. Yeah.
First, thank you so much for this presentation. This has just been incredibly insightful, so thank you. This speaks to, I think, the first question that was asked and also the second. What do you suggest for behavioral health providers in integrative settings, interfacing with nurses, medical assistants, also physicians who are experiencing some of the challenges that you presented on today, while maintaining professional boundaries as they're our colleagues, not our patients?
Yeah.
What do you suggest in terms of navigating that relationship?
That's tough. That's really tough. One of the things my primary care docs really lament is they're having to do mental health care when they're not mental health providers. Like, I'm a primary care doc. I do diabetes, I do hypertension. I don't do ADHD, depression, et cetera, et cetera. So really, the integrated model is one of the solutions to a major problem. So you're just being there as a clinician, taking that load off, being the person who can actually address those issues effectively is really a big piece of the puzzle. That's huge. And that's fairly new integrative practices. More of that across the United States, please. If you're worried about somebody in particular, that's a really tricky situation, and I would say it depends on what kind of a collaborative relationship you have with them. So you might just say, hey, feel like maybe you're struggling a little bit. Just want you to know that I care, that I see it. I see you. I see you. And then they take that home and think about it and probably get really defensive and, all the things. I mean, we can lead a horse to water, right? Thank you for the question.
Thank you so much.
Thanks for your attention.